Welcome to my lecture on asthma, Chapter 14. Asthma is characterized by three things: airway inflammation, inflammation on the inside of the airway, and bronchial spasm or muscles tightening on the outside of the airway, and excessive amount of mucus secretions. You can see that pictured here. A history of wheezing, shortness of breath, chest tightness, and cough may also be present. Symptoms may vary over time and in intensity. They may be mild to severe, and airflow limitation may also vary from mild to severe. Allergic asthma, or atopic asthma. This asthma phenotype is the most easily identified, and it typically appears in childhood. It is also associated with a family history of allergic disorders such as eczema, allergic rhinitis, or food and drug allergies. Before treatment, the sputum of these patients often reveals eosinophilic airway inflammation. Patients with allergic asthma usually respond well to inhaled corticosteroids. Non-allergic asthma. Non-allergic asthma is a phenotype that is seen in adults who do not have allergies. The cellular characteristics of the sputum in these patients may be neutrophilic, eosinophilic, or have only a few inflammatory cells. Patients with non-allergic asthma do not usually respond well to corticosteroids. Late onset asthma. Some adults, especially women, develop asthma for the very first time late in adult life. These patients are usually non-allergic and typically require higher doses of inhaled corticosteroid therapy and are relatively resistant to treatment with any kind of corticosteroids. Asthma with fixed airflow limitation. Some patients with a long history of asthma develop a fixed airflow limitation that is believed to be caused by airway remodeling. That is, the airway structural changes have happened and are permanent. These can be fibrosis, increased smooth muscle mass, enlargement of glands, neovascularization, and epithelial alterations. Asthma with obesity. Asthma with prominent respiratory symptoms and little eosinophilic airway inflammation is commonly seen in obese patients. Body mass index greater than 30 kilograms per meter squared or morbid obesity, in addition to asthma, is more difficult to control in obese patients. Updated clinical guidelines for asthma have been developed and disseminated on a regular basis by both the National Asthma Education and Prevention Program and by the Global Initiative for Asthma, or GINA. In 1991, the first evidence-based asthma guidelines were published by the National Asthma Education and Prevention Program. with the help of the National Heart, Lung, and Blood Institute and the National Institutes of Health. Today, these guidelines by the National Asthma Education and Prevention Program are structured around the following 4 components: assessment and monitoring of asthma, patient education, controlling factors contributing to asthma severity, and how to treat asthma. GINA, or the Global Initiative for Asthma, was first introduced in 1993 by the following organizations: the National Heart, Lung, and Blood Institute of the National Institutes of Health and the World Health Organization. GINA's specific goals are to increase awareness of asthma and its public health consequences, to promote the identification of reasons for increased prevalence of asthma, to promote the study of the association between asthma and the environment, to reduce asthma morbidity and mortality, to improve asthma management, and to improve availability and access of effective asthma therapy. Every year, the role of GINA is to collect the most current scientific evidence associated with asthma care and transfer this information into practical and user-friendly formats. Once this is done, then GINA disseminates those most current standards of asthma care to health professionals, organizations, and public health professionals. Anatomic alterations of the lungs include reversible bronchial smooth muscle constriction, airway inflammation, which is swelling on the inside of the airway, increased airway responsiveness to an assortment of stimuli. During an asthma attack, the smooth muscles surrounding the small airways constrict. Over time, smooth muscle layers hypertrophy and can increase to 3 times their normal thickness. The airway mucosa becomes infiltrated with eosinophils and other inflammatory cells, which in turn cause airway inflammation and mucosal edema. Microscopic crystals called Charcot-Leyden crystals are formed from the breakdown of eosinophils in patients with allergic asthma. These crystals are slender and pointed at both ends and have a pair of hexagonal pyramids joined at their bases. They vary in size and may be as large as 50 micrometers in length. The goblet cells proliferate and bronchial mucus glands enlarge. The airways become filled with thick, sticky, white, tenacious mucus. Extensive mucus plugging and atelectasis can develop. As a result, smooth muscle constriction, bronchial mucosal edema, and excessive bronchial secretions, air trapping, and alveolar hyperinflation develop. Notice a normal airway as compared to an asthmatic airway. Normal airway, open, no mucus. Asthmatic airway, swollen, red, bronchial muscles constricted, and mucus. When this happens for often enough and long enough, the basement membrane of the mucosa may become thicker than normal and may become permanently fibrotic. This is known as remodeling. In summary, the major structural changes that you will see: smooth muscle constriction of the bronchial airways or bronchospasm, excessive production of thick whitish bronchial secretions, mucus plugging, hyperinflation of the alveoli or air trapping, and bronchial wall inflammation that can lead in severe cases to fibrosis and remodeling. Etiology and Epidemiology. About 18.4 million adults, about 7.6% of all adults, and 6.2 million children, or 8.4% of children, have asthma. That's a total of about 25 million people. According to the CDC, about 6.5% of all physician office visits are asthma-related, and about 1.9 million visits to the ER department every year have asthma as the primary diagnosis. Asthma is the cause of about 3,651 deaths per year in the United States. Asthma is nearly twice as prevalent in young boys as young girls. In the adult, however, asthma is more common in women than in men. The World Health Organization estimates that about 235 million people worldwide suffer from asthma. Low and middle income countries account for more than 80% of asthma's mortality rate worldwide. Also, worldwide, asthma is the most common chronic disease among children. Clearly, the effect of asthma on health, quality of life, and economy is substantial. Let's consider risk factors in asthma. First, let's look at host factors. Asthma authorities are not in full agreement as to how risk factors for certain kinds of asthma should be categorized. Some would like them to be placed under extrinsic or intrinsic, or allergic versus non-allergic, or atopic versus non-atopic. However, we are going to put them into host factors, which are primarily genetic, and that result in the development of intrinsic asthma, or environmental factors that trigger the clinical manifestations, or extrinsic asthma, or a combination of both. Host factors, primarily genetic or intrinsic, or environmental factors, primarily extrinsic. So host factors, genetics. There are several types of persistent and intermittent genetic phenotypes of asthma. Although the genetic factors associated with asthma are varied and not fully understood, the search for genetic links to asthma has primarily focused on the following four areas: the production of allergen-specific immunoglobulin E, IgE antibodies, airway hyperresponsiveness, inflammatory mediators, and T helper cells, Th1 and Th2, which are an important part of the immune system. T helper cells are the lymphocytes that recognize foreign pathogens, and in the case of autoimmune disease, normal tissue. T helper 1 cells are involved in what is called cell-mediated immunity, which usually deals with infections caused by viruses and certain bacteria. They're the body's first line of defense against pathogens that invade the body's cells. They tend to be inflammatory. The T helper 2 cells are involved in humoral-mediated immunity, which deals with bacteria, toxins, and allergens. They are responsible for stimulating the production of antibodies in response to extracellular pathogens. They tend not to be inflammatory. Sex. Before the age of 14 years, the prevalence of asthma is nearly 2 times greater in boys than in girls. Asthma severity in boys generally peaks around age 5 to 7 years and lessens dramatically during puberty. As children become older, the prevalence of asthma narrows between the sexes, as many girls experience the onset of asthma during puberty. In adulthood, the prevalence of asthma is greater in women than in men. Obesity. Asthma is more commonly seen in obese people, body mass index or BMI greater than 30 kilograms per meter squared. Obese patients have more problems with lung function and more comorbidities compared to normal weight patients with asthma. Let's move on to environmental factors or extrinsic factors. Allergens. Outdoor and indoor air pollution. Outbreaks of asthma exacerbations have been reported in areas of increased levels of air pollution, especially when the environmental air is full of air pollution with particles that are less than 5 microns in diameter. PM 2.5 microns is especially respirable. The role of outdoor air pollution in causing asthma remains controversial. Similar associations have been reported in relation to indoor air pollutants such as cigarette smoke and fumes from gas and biomass fuels used for heating and cooking, cooling, molds, and cockroach infestation, seen in sick building syndrome. Occupational sensitizers, or occupational asthma, which is also reportable to the CDC. Occupational asthma is defined as asthma caused by exposure to an agent encountered at work. More than 300 different substances have been associated with occupational asthma. Occupational asthma is seen predominantly in adults. It is estimated that occupational sensitizers cause about 15% of cases of asthma among adults working. High-risk work environments for occupational asthma include farming, agricultural work, painting, including spray painting, cleaning, and plastic manufacturing. Most occupational asthma is immunologically mediated and has a latency period of months to years after the onset of exposure. Although the cause is not fully understood, it's known that an IgE-mediated allergic reaction and cell-mediated allergic reactions are often involved. Infections, predominantly viral. Although bacterial infections may trigger asthma, viral upper and lower airway infections are more likely to contribute to asthma. For example, several viruses seen during infancy are associated with the activation of the asthma phenotype. Such viruses include RSV or respiratory syncytial virus, human rhinovirus or HRV, and parainfluenza virus. These conditions are often produce a pattern of symptoms that parallel many features of childhood asthma. For example, it's estimated that about 40% of children with RSV infection will go on to continue to wheeze or have adult asthma later in life. The bionome. A collection of microorganisms and their genetic material, both within the host and the host's surrounding environment, is associated with the development of allergic disorders in asthma. For example, delivery by cesarean sections have a higher risk factor for developing asthma because of the microbiome. Tobacco smoke. Exposure to tobacco smoke, both in womb and after birth is associated with a greater risk for developing asthma-like clinical manifestations in early childhood. Infants of smoking parents are 4 times more likely to develop wheezing in the first year of life. In fact, the concern of exposing children to tobacco smoke has resulted in several states enacting legislation that prohibits smoking in motor vehicles when children are passengers. Diet. Research has suggested that infants given formulas of intact cow's milk or soy protein have a higher incidence of wheezing in early childhood as compared with infants given breast milk. Studies have also indicated that certain characteristics of Western diets, such as increased use of processed food, decreased antioxidants in the form of fruits and vegetables, increased omega-6 polysaturated fats found in margarine and vegetable oils and eggs, diminished amounts of omega-3 polysaturated fatty acid found in fish oil, and foods that clearly cause an allergic or asthma-like symptoms, usually demonstrated by oral challenges, should be avoided. Other risk factors associated with asthma are drugs. Asthma exacerbations are associated with ingestion of aspirin and other non-steroidal anti-inflammatory. Beta-blocking drugs administered orally, such as propranolol, and intraocular medications for glaucoma are also associated with asthma exacerbations. Food additives and preservatives. Sulfites, common food and drug preservatives found in foods like processed potatoes, shrimp, dried fruits, beer, wine, and sometimes even lettuce and salad bars, have often been associated with causing severe asthma exacerbations. About 5% of the asthma population is sensitive to foods and drink that contain sulfites. The synthetic lemon yellow dye tazarotene may provoke an asthma episode as well. Exercise-induced bronchoconstriction. Asthma is sometimes associated with vigorous exercise. In children, exercise is a common trigger for asthma symptoms. Research has shown that the drying and cooling of the airways during exercise is the primary trigger mechanism. Running in cold air is an activity that causes the most bronchospasm, whereas swimming in a warm environment causes some of the fewest asthmatic symptoms, assuming that the water is non-chlorinated and the pool area is well ventilated. GERD, or gastroesophageal reflux, or regurgitation, appears to significantly contribute to bronchoconstriction in some patients. The precise mechanism of this relationship is not known. The patient may complain of burning, substernal pain, belching, or a bitter acid taste, particularly when lying down. Incidentally, unrecognized GERD is one of the most common causes of a hard-to-diagnose cough. Unrecognized sinusitis is the other most common cause. Sleep or nocturnal asthma. Patients with asthma often have more breathing difficulty late at night. Late at night or early in the morning, serum cortisol levels drop. Precipitating factors associated with nocturnal asthma include GERD, retained airway secretions caused by a suppressed cough reflex during sleep, and exposure to irritants or allergens in the bedroom and prolonged time between medication doses. Eradication of nocturnal asthma is one measure of good asthma control. Emotional stress. In some patients, the exacerbation of asthma appears to correlate with emotional stress and other psychological factors. This is most likely mediated by histamine release from circulating mast cells. premenstrual asthma or catamenial asthma. Clinical manifestations associated with asthma often worsen in women during the premenstrual and menstrual cycles. The symptoms often peak 2 to 3 days prior to the menstrual cycle. Premenstrual asthma correlates with the late luteal phase of ovarian activity, the phase during which circulating progesterone and estrogen levels are low. Allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis, ABPA, is characterized by exaggerated response of the immune system or hypersensitivity reactivity to Aspergillus fungus, which we'll talk more about later. It's an important fungal disease. However, in patients with asthma and cystic fibrosis, ABPA can cause airway inflammation and bronchospasm. Patients with ABPA often have symptoms of poorly controlled asthma such as wheezing cough, shortness of breath, and reduced exercise tolerance. So how do we diagnose asthma? The diagnosis of asthma can be challenging. For example, in early childhood, a diagnosis of asthma is frequently based on assessment of the child's symptoms and physical findings, and good clinical judgment. For instance, the child has a 5 to 10-fold greater chance of being diagnosed with asthma if the child has what is referred to as either one major criterion, such as a parent with asthma, or the presence of atopic dermatitis, or 2 minor criteria, such as allergic rhinitis, wheezing apart from colds, or peripheral eosinophil count greater than 4%. In older children and adults, a complete history physical examination, along with demonstration of a reversible and variable airflow obstruction on a PFT, will in most cases confirm a diagnosis of asthma. However, in an elderly patient, asthma often goes undiagnosed because of comorbid diseases that complicate the diagnosis. In addition, the diagnosis of asthma is often missed in patients who acquire asthma in the workplace. This form of asthma is called occupational asthma. Because occupational asthma usually has a slow and insidious onset, the patient's asthma is often misdiagnosed as chronic bronchitis or chronic obstructive pulmonary disease. As a result, the asthma is either not treated or treated inappropriately. And finally, although asthma usually can be diagnosed and distinguished from COPD, some people will have both disorders, and it can be hard to distinguish. Some evidence for diagnosis of asthma: symptoms that worsen at night, awakening the patient. Symptoms that worsen in a seasonal pattern. The patient has eczema, hay fever, or a family history of asthma or atopic diseases. Symptoms occur or worsen in the presence of animals with fur, aerosol chemicals, changes in temperature, either hot or cool, changes in weather, domestic dust mites, exposure to drugs such as aspirin or beta blockers, exercise, pollens, viral respiratory infections, exposure to cigarette smoke, or strong emotional expression. Diagnostic tests and monitoring for asthma. because patients often have normal lung function between asthma episodes. Measurement of airway responsiveness to a bronchial provocation test, allergy test, and exhaled nitric oxide test may be helpful in the diagnosis of asthma. However, an FEV1 greater than 12% or greater or equal to 200 milliliter change after inhaling a bronchodilator signifies in an adult response, a reversible response for asthma. In children, greater than 12% of their predicted signifies a response in asthma after inhaling a bronchodilator. Peak expiratory flow rate, if a person is old enough. Daily variability is greater than 10%. In children, greater than 13%. FEV1 FVC ratio is reduced. Normal is more than 0.75 to 0.80 in adults. Normal is greater than 90% in children. FEV1 increases by greater than 12% and or greater than equal to 200 milliliters after 4 weeks of anti-inflammatory therapy, or the peak expiratory flow rate by greater than 20% on the same peak expiratory flow meter. Let's talk a little about these other diagnostic tests for asthma that may help. First, let's talk about the bronchial provocation test. Because airflow limitation may be absent during the initial assessment in some patients, a bronchial provocation test may be helpful in assessing airway hyperresponsiveness. This is most often done with inhaled methacholine. However, histamine, exercise, eucapnic involuntary hyperventilation, or inhaled mannitol may be used. One of the most common things used is cold air. Allergy testing. The presence of allergic asthma can be assessed by skin prick testing or by measuring the level of specific immunoglobulin, or IgE, via RAST test, or radioallergosorbent test. In serum, the skin prick test uses common environmental allergens, is inexpensive, and has a high sensitivity. It's simple and fast to perform. The measurement of IgE is more expensive, but may be preferred by patients who don't wish to undergo a series of needle pricks. Exhaled nitric oxide. Clinicians are now able to judge the control of eosinophilic airway inflammation caused by asthma by measuring fractional concentration of exhaled nitric oxide, or FeNO. In adults, the FeNO is less than 25 parts per billion. The normal FeNO in children is less than 20 parts per billion. The FeNO levels rise with eosinophilic airway inflammation. A high FeNO, greater than 50 parts per billion, suggests a need to increase the patient's controller medications. A common cause of increased FeNO is patients' lack of compliance with their prescribed inhaled corticosteroids. Let's talk about the diagnosis of asthma in special populations. Cough variant asthma. Some patients have a cough variant asthma as their primary and maybe only symptom. It's especially common in children and most often seen at night. Evaluations during the day are often normal. In these cases, tests directed at the patient's airway hyperresponsiveness and search for possible sputum and blood eosinophils may be helpful in confirming the diagnosis of asthma. Occupational or work-aggravated asthma is frequently missed because it's slow with onset and only seen at work. It's often misdiagnosed as chronic bronchitis or COPD and treated inappropriately, if at all. The development of a constant cough, wheezes, and rhinitis should raise suspicion, especially in a non-smoker. The diagnosis of occupational asthma requires a defined history of occupational exposure to sensitizing agents, the absence of asthma symptoms before beginning employment, and a documented relationship between the asthma symptoms and the workplace. And then an improvement in asthma symptoms when away from the workplace. Athletes. Exercise-induced bronchospasm, or EIB, should be confirmed by lung function testing, including a bronchial provocation test. Conditions associated with asthma, such as rhinitis, laryngeal disorders, dysfunctional breathing, cardiac conditions, and overtraining need to be excluded. Pregnant women. Women planning a pregnancy should be asked if they have a history of asthma, so the appropriate advice can be provided regarding their asthma management and medication. The elderly. Asthma is often underdiagnosed in the elderly because of their acceptance of being short of breath as being normal due to old age, lack of fitness, or reduced capacity. A careful history and physical examination combined with an EKG, chest X-ray will help in diagnosis. In addition, a history of smoking or biomass fuel exposure, COPD, and overlapping asthma and COPD should be considered. Smokers or ex-smokers. Asthma and COPD can be difficult to distinguish, especially in older patients. Smokers and ex-smokers and patients with COPD and asthma overlap syndrome can be tough to judge. The history and pattern of symptoms and past records can be helpful in distinguishing these patients from patients with asthma. Confirming the diagnosis of asthma in patients taking controller medications. Between 25 and 35% of patients with a diagnosis of asthma cannot be confirmed as having asthma. In these patients, a trial of either a lower or higher dose of controller treatment is recommended. If the diagnosis cannot be confirmed, the patient should undergo an expert evaluation and diagnosis. Obese patients. Because the respiratory symptoms associated with obesity can mimic asthma, it's important to confirm the diagnosis of asthma with objective measurements of variable airflow limitation. This is the end of part 1 for the asthma presentation. Please watch part 2. Thank you for your time and attention.